He will not force the weakness.
Well, thank you for inviting Ben and myself to talk about some of the work we do. And today, what I want to talk about is treating intractable pain syndromes. And also present to you that sometimes a classic example of functional surgery has been that 20, 25 years ago, the only therapy we had was to target deep structures in the brain and lesion them to alter symptomatology. And therefore, it seemed to us that when you could target the same area with electrodes and stimulate at high frequency to block or drive those targets, we would achieve the same results. Sometimes it doesn't happen, or not to the degree we thought. Now, Oxford Functional Surgery was founded in 1993 by myself and a very small group of folks, but now we're quite a big group. We treat movement disorders, Parkinson's disease, dystonia and tremor amongst movement disorders, but also intractable pain syndromes, complex regional pain syndrome, phantom limb, anesthesia dolorosa, post-stroke pain. And today, we're the UK's largest neuromodulation center, and in size, 15th in the world in number of procedures we do. We have a long history of pioneering procedures and an active program of research. What is deep brain stimulation? Let's see, let's get this to work. Oops. Yeah. Well, basically what deep brain stimulation does is we take a patient with any affliction, and if we know the target region from a pacemaker implanted under the skin, very much like a cardiac pacemaker, we have wires running up to connect to electrodes implanted deep brain in the deep brain target and alter its function electronically. And we can do that remotely, so the patient never requires repeated surgery for that. But what we do have these days are rechargeable pacemakers, which last upwards of 30 years, which may induce, mean that patients only have one such implant in their lifetime. Yeah. Now, what are the advantages of deep brain stimulation over lesional procedures? One, it's reversible, unlike lesioning. In the very old days, if you made a miscalculation and got a side effect and made a lesion, the patient was stuck with it for the duration of his life. It's adaptable. We can change the settings to best fit the patient's symptom relief. But there are disadvantages. Lesional surgery is very cheap. To make a lesion costs nothing. But to implant one of these pacemakers, the whole treatment therapy cycle costs about £40,000. We implant foreign material with the risk of infection, with the risk of breakdown, risk of equipment failure. The current devices interact with electromagnetic devices such as MRI scans. Now, what is the technique? We take very good imaging of the brain, MR scans preoperatively. We fit the patient into a frame and then do a CT scan. And then if we merge the two, using the frame, we can apply three-dimensional Cartesian coordinates, a bit like a GPS system, to any target within the irregular structure that is the brain. And then once we have done that, we can calculate where we enter the skull and where we want to end up. And with the use of the frame, we can drill a hole into the skull with a stereotactic drill. So we can make it very small so we only hit the target. And then we pass the electrode in. We plate it to the skull, and particularly for pain, we externalize these electrodes with temporary leads to test the efficacy of pain relief on the ward for a week. Because theater is stressful, Sometimes patients are so stressed that they need some sedation, so they can't actually tell you the degree of pain relief they have achieved. If they're happy, we give them a general anesthetic and implant the pacemaker with its connecting cables. Neuropathic pain is one of, to my mind, the biggest indication of deep brain stimulation. The definition for it is very simple now: pain caused by a lesion or disease of the somatosensory system. It is estimated to affect 7 to 8% of the general population in Europe. And of this large number, 5% of them remain disabled despite medication. Now, there have been targets in the past that even I have used 20, 25 years ago. And what are they? There's the periaqueductal gray here, which is just off the midline of the brain. And more laterally is the sensory thalamus. People have used other targets as illustrated here, but the crux of the major lesional procedures were done in the thalamus and the periventricular gray. If we stimulate the sensory thalamus, we get, if we're in the right anatomical region of the sensory thalamus, we get a sense of tingling, of paresthesia on table, and hopefully in the area of pain. And once we get that, that electrode is fixed in situ. If we go further down to the brain, into the periaqueductal gray areas illustrated here, what patients feel instead of pain is that that area of pain feels like it's been wrapped in a warm blanket, a very comforting feeling. Now, these are illustrations of what happens. This is a patient with a phantom leg pain who was absolutely unable to have it touched. And when we pass the electrode in and stimulate, you can see that the pain has been completely blocked. And I did him, I think, about 10, 12 years ago, and he still remains pain-free. So it's a very eminently tolerable procedure. The next case is a gentleman with periventricular gray stimulation with right-sided brachialgia after injury from a cervical disc protrusion. And this illustrates, again, yeah. Now this is him, if you believe it or not, about 10 minutes after he came out of theater. And you can see that his right arm, there you see it, he can do press-ups without any discomfort. And so that's the degree of pain relief you can achieve almost on table. And he didn't stop at that. He wanted to prove how good the pain relief was. So you can see with that painful arm, he could support himself. How do we stop? So what I'd like to present to you is first the results of using these standard targets. And the reason we use deep brain stimulation in these standard targets were that 20 plus years ago, when we used those same targets for lesioning with the same on-table effects, patients got pain relief. But pain is like water. It'll always find its way around a lesion. So after 9 to 12 months, the pain would recur or even change its area of distribution. And that's why, given the long history in movement disorders, at least, we know that if there's an effective lesional target, we can put an electrode there and modify function, usually to the same effect. So this is deep brain stimulation of this classical targets, periaqueductal gray and periventricular gray. And over this period of time, we assessed 197 patients. Of that group, 56 were unable to obtain funding, and 29 were declined surgery. 50 had medical contraindications. 7 had psychological problems, and 3 were not medically best managed. So 87 went on to trial. And of those 87, 76 went to full implantation because they were happy with the results. And in 15, we lost follow-up, usually because there were strokes and with long-term follow-up, quite a few of them died. So with 61, we had long-term follow-ups. And you will see from here that in the short term, there's an improvement in the VAS scores. There's improvement in the functioning SF-36, in the Euroqual 5D, and the health state. But is this sustained? It is so, because if you look at the long-term outcomes of this cohort of patients, you'll see that the short-term benefits were maintained at follow-up even greater than 4 years. So DBS for pain is efficient and effective in relieving neuropathic pain of various etiologies, is sustained long-term. But the effectiveness of the therapy varies between etiologies and the patients. And there are patients with ineffective deep brain stimulation. And this is largely seen in patients with high cervical cord injury with whole body pain, and patients with strokes who have hemi-body pain usually. And stimulating the classic somatosensory targets cannot find coverage of all that area of pain. And therefore, we looked back, as we have done in functional neurosurgery, at targets used in the past. Now, this is a slide put together by Bin because his classical knowledge is much better than mine. What is the origin of the suffix algia? And it's from a Greek mythology, the spirits, the demons of pain, considered to be attributed to 3 sisters. Lut, pain intensity, Akos, affective aspect of pain, and Anis, the cognitive grief side of pain. And we could selectively look at, with selection of target, choose any of these to modify. So, looking back at how we treat widespread pain, we go to the anterior cingulate. Now, this has a history even longer than stereotactic surgery itself when it was performed through open craniotomies. And as you can see, this is the area of interest. And it was first excised for intractable pain here in Oxford in 1937 by Hugh Cairns. So, why did he choose it? Well, there was a very long history going back to the 40s, as you see. Frontal lobotomy patients had pain, but were not bothered by it. And again, if you selectively did a cingulotomy or even a cingulectomy, patients continued to have pain, but it didn't bother them. So we did a series in Oxford for intractable terminal pain, because the history of cingulotomy is that if someone has 6 to 9 months left to live and you do a bilateral cingulotomy, these patients become totally indifferent to their pain and stop their pain medication. And so we used to do quite a few here until palliative care medicine felt that medical management was the best way forward, which is not always the case. And as you can see, cingulate lesioning has a very long history with multiple authors. But it does have a 50 to 60% hit rate, success rate. And as I say, the results aren't sustained. This illustrates a case of ours where we did bilateral cingulotomy in a patient with terminal mesothelioma. From being comatose on opiates, after this procedure, he went off drugs, took his family on holiday, and a month later, on his return, died. But during that period, we restored him to his family. So, if lesional surgery could be so effective, could we use the same target as we did in movement disorders, transfer the conclusions of lesions to that of deep brain stimulation? Because we still have a huge population of patients with intractable neuropathic pain syndromes. And this was the first detailed case report of deep brain stimulation of the anterior cingulate cortex. There was a case prior to this which was with poor imaging and poor outcome quality in that single case, we were unable to interpret usefully. And in this case, the pain relief was so dramatic, we went on to start our series on the same basis of functional surgery, transferring the concept of lesional procedures with deep brain stimulation. So this is where we put the electrodes deep into the anterior cingulate, and we put it 20 millimeters posterior to the tip of the frontal horn of the lateral ventricles, and put the deepest contact in the corpus callosum, exactly the target we use for lesioning. It does use a high degree of stimulation, which we'll come to later, 5 volts, 130 hertz, and 450 microseconds, which is quite a wide pulse. And we went on to publish a series of targeting the anterior cingulate. And it had the most phenomenal effect in these patients. When we implant and stimulate, they don't really feel much. And when we externalize and trial them, interestingly, nothing happens for about a couple of days. And then on the third day, when you ask a lot of these folks, what they report to you is that they are doing more. The pain is still there, but it doesn't bother them. And we carry on to implant. And these are the early results of the anterior cingulate stimulation. And you can see improvement in various parameters again. The VAS score, the SF36, MPQ, the Euroqual 5D, and the health state. So it looks very favorable. And this is what a patient reports. This gentleman had hemibody post-stroke pain. So you can see he says, I don't actually think about the pain. I still feel the pain, but I don't think about it. Does it give you unwanted effects? And the patient says no. So overall, he felt it was working actually. Unfortunately, 2 years later, another stroke took him away from us. But for that period of time, he was well relieved. So, where does Bin's input come in? After a long-term, 2 or 3 years follow-up, some patients with cingulate stimulation reported stereotypic neurological events. Hard to interpret, and I needed Bin's expertise. Some were diagnosed with epilepsy, treated with anti-epileptics, but no change in the rate of the events. However, seizures are an uncommon complication of deep brain stimulation and generally an early complication of surgery. So from here, I will pass it on to Bin, because from here he took on the investigation of this problem and its resolution. May I hand in Bin?
Thank you. So I was asked to review 1 or 2 patients, and then in the end we've ended up reviewing everyone who's had an implanted ACC stimulator. And when I was first asked to see these patients, I was a bit dubious, because I come from a movement disorders background, and seizures after DBS for epilepsy, for Parkinson's or tremor, is vanishingly rare. It's less than 0.5%. And it usually happens to patients who've had some sort of event during surgery, a little bit of hemorrhage, a post-insertion stroke, something like that. And none of these patients had those events. So to imagine that these patients were then getting seizures 1 or 2 years down the line was a bit unusual. So I was a little bit dubious. I interviewed the first patient and then realized we need to look at this a little bit more in detail. And what we did is we admit them for video telemetry. And I want you to try and spot the seizure. Have you spotted it yet? Because if you haven't spotted it yet, you're not going to. That's the seizure. You've just missed the seizure. So I'll show you another video. See whether you can spot the seizure again. So the technician is questioning her. She's not really responding. She's mumbling something. And now she starts to wake up. It's a transient 2 to 3 second event. It's called a behavioral pause or a dialectic seizure. Very, very easy to miss. On the first occasion, the husband is in the room and he's never picked it up. On the second occasion, the EEG technician only picks it up because she's looking at the EEG and she can see that it's becoming abnormal and then questions the patient and then records that the responses are abnormal. So brief, very, very brief seizures, 2 to 3 second seizures, easily missed. Recorded by the patient as not being able to speak or transient sense of feeling distant. So very hard to diagnose and so very easily missed. So we then looked at everybody who had ACC implants. So 20 people had an implant, ACC implant. 2 of those developed DBS system infection, quite common with DBS, at the standard rate that happens for DBS patients. 5 patients developed what we call tolerance, which is habituation to the effects in the first year of therapy, requiring either that it's switched off or they get explanted. So there were 13 patients who were chronically implanted for more than 1 year, and all of them retained the system. Out of that, 4 have clinically definite seizures. And out of that, 2 have de novo epilepsy, by which I mean if you switch off the DBS, they still have seizures. And that's a very high rate. And then 2 had events of uncertain significance. These patients are very, very complex. One of these patients is alcoholism, was diagnosed with alcohol withdrawal seizures, not really clear, won't come in for follow-up. But at least 4 developed seizures. And to really get a feel for what's going on, I'm going to take you through the clinical history, and I'll try and illustrate how this builds up. So it's a bit dry, but bear with me. The first patient I want to tell you about is an 80-year-old who underwent ACC DBS for post-stroke pain. 12 months after the op, he started noticing some difficulty in what he called expressing words. This is the transient pause. And it happened when he switched on the stimulation. When he turned it on, he would turn it off at night and then turn it on in the morning every day, or his carer would do it for him. And when they turned it up, the system ramps up. And during that ramping up period, he would suddenly get this difficulty speaking. Lasts a few seconds, and then he's back. And he just leaves the stimulator on, doesn't have another event through the day. He then noticed on his own, he didn't tell anybody else, he noticed on his own that it tends to happen above a certain threshold of stimulation. So we measure stimulation intensity in voltage or milliamperes. So we say he noticed that initially he'd only get it at 6, but over time he noticed that he would get it at 4 and then 3.5, and he limited his stimulation to 3.5 because he knew that above that stimulation he'd get this little behavioral rest. So in telemetry, the standard recording was entirely normal, but when we ramped it up above 3.5 to 4.5, he exhibited some emotionality and then described having word finding difficulties after a brief pause and then resolved. And the EEG during this event is not diagnostic of a seizure, but was clearly abnormal, started to organize and became normal. And the clincher for me was that when you turned it up a bit higher to 5.5, the same event happened, it lasted longer, and the EEG changes lasted longer and happened during ramping. So, and this gentleman, over a long period of time in the past year, has noticed that it started happening even at 3.5 milliamps. And then he's had to switch it below 3.5 milliamps. That level, he felt that it wasn't really worthwhile, he switched it off. But he's now been in touch recently to say that, in retrospect, even 2.5 milliamps was effective for pain. He's worse off than he's ever been since he's had the ACC DBS. So this person has events that can be reproduced by stimulation above a certain threshold. There's been a progressive fall in stimulation intensity for seizures, threshold for seizures over time. And the events stop when the stimulation stops. So he's got stimulation-induced seizures. Pretty rare, pretty rare. Patient 2, illustration, so we're building up here to show you how it evolves. It's a 57-year-old who had post-stroke pain and ACC DBS. On post-op day 6, stimulator was switched on, and he reported a dramatic relief of pain at 7.5 milliamps. He was then dialed up to 8 milliamps, a very high setting, but that's what he needed for symptomatic relief of pain. And a few hours later, he had 2 brief generalized tonic-clonic seizures, self-resolving. So that's stimulation-induced seizure, but that's clearly above a certain level. He gets a tonic-clonic seizure, very different to the one that we're talking about. So 2 days after the convulsive seizure, the DBS was switched on again, and very carefully the level was titrated up. And at 6, the person titrating it up noticed that he had a brief spell of loss of awareness and lip smacking, which is a sort of automatism, which is a feature of seizures from that area. So the settings were reduced to 5 milliamps, below that seizure threshold, and then the patient was very well controlled. He had excellent relief of pain. He was very happy, left, came back 2 months after, and said that the pain's increasing and he wants a little bit more stimulation. So settings were increased to 5.5, still below that seizure threshold, and he was sent home. He came back, and he was on 7 milliamps because he has a patient programmer and he turned it up himself to 7 milliamps, so 1 milliamp above that seizure threshold. So he was advised that that's not a good thing, and they was reprogrammed to a cycling mode where it switches off for a period of time so that he's not getting constant supra-threshold stimulation. And they set a maximum limit of 6 milliamps. So he could go no more than what was previously recorded to be the seizure threshold. He came back for his 2-year follow-up, and he noticed that he gets lip smacking at current thresholds greater than 4 milliamps. And it started a few months earlier, he said, at that point in time. So during telemetry, he didn't show any interictal changes, no changes between, and he refused ramping over 4 milliamps. His stimulation intensity, stimulation threshold for seizures has also been falling, and he's also switched off the stimulator because he feels at efficacious settings he has events, so he switched it off. So this guy has a step further. So he's got events that can be reproduced by stimulation. He's got a progressive fall in stimulation intensity threshold for seizures. But then you get this sense that stimulation just below the seizure threshold contributes to this progressive fall of seizure threshold. But events still stop when stimulation stops. So he also has stimulation-induced seizures. And then we have patient 3. So this is where it gets interesting. Patient 3 was 49 years old, and he had syringomelia, so in his cervical spine. And he had chronic right arm and leg pain. Post-op was fine. He first reported loss of focus and difficulty expressing words, and a feeling that his left arm was stiffening, lasts a few seconds at a time, just like the other people, at around 12 months. Same sort of time interval. So immediate reaction, because now this is the 3rd one along and people are sort of tuned in on the clinical team to things happening. The right lead settings were reduced by to 5 volts of power output. This event ceased for a month and then returned, but he didn't tell anyone. But 3-month review, people actually asked, are these events happening? And he confirmed that he was having 10 events a day. So the current was further turned down to 0.5 volts, which is basically it's been switched off. And 6 months later, the patient confirmed that he was still having 2 to 3 events per day. So at very, very, very low stimulation voltage, pretty much it being switched off, he was having events. But pain was back to pre-implant levels. It was unbearable. So he was started on an anti-epileptic drug to enable DBS to be restarted in conjunction with his neurologist from the referral center and the pain team at the referral center. The event ceased completely on a gram of levetiracetam, DBS was restarted, and then came back 9 months later. Seizure frequency, event frequency was 50 per day. And he hadn't told anybody that it was increasing in frequency because he was worried that you'd switch off the stimulator. So his ictal EEG was normal, which is not surprising because these are very deep structures. Sometimes you don't see the propagation of the signal to the surface. But interictally, the EEG was abnormal. It changed. He had sharp transient spikes over the right bits of the brain for an ACC seizure. And this was also seen when the DBS was switched off. So he had, and even though the DBS was switched off, he continued to have 3 attacks per day. And at 3 months, he still had 3 attacks per day. And this is effectively de novo epilepsy. So, like the other people, he has progressive fall in stimulation intensity threshold. He has events that can be reproduced by stimulation above a particular threshold. But then you confirm that continued stimulation above that threshold leads to an increasing event rate. You go from 3 events a day to 50 events a day if you just carry on stimulating above that seizure threshold. Eventually, the events do not stop when stimulation stops. It's no longer stimulation-induced seizures. The diagnosis here is stimulation-induced de novo epilepsy. That's pretty much a first, I think. And the video for the patient that we saw, that's patient 4, although that's the first patient that I saw, I've reviewed, and she has the same. It's the same situation. She has stimulation-induced de novo epilepsy following stimulation over a prolonged period of time. So a lot of questions here because this is actually brand new territory for DBS. How does this happen? Well, this is a phenomenon called kindling, we think. So in experimental models of acquired epilepsy, animal models of epilepsy, there are a couple of ways to induce epilepsy in a test animal. One is to have produce status epilepticus using chemicals or electrical stimulation, and that is works on the principle of seizures beget seizures. So if you produce a prolonged seizure through chemical or electrical means, that the brain, the neuroplasticity in the brain results in seizures, spontaneous seizures. The other is traumatic injury, so through cutting or trauma. And then one of the commonly used one is the kindling model of seizures, which is when you have repeated subthreshold electrical stimulation. So what they do is that they on your left there is the electrical stimulation, and you stimulate just enough to produce a brief after discharge. So the little spikes you see afterwards are after discharges. And if you repeatedly produce after discharges in the animal, they go through what they call Racine stages. Racine stage 1 to 5, and the animals exhibit a different type of semiology from these events. And it progressively builds up at Racine stage 5. You have a fully kindled animal who has spontaneous seizures. You have an animal model of epilepsy. So was this predictable? Should we have predicted it? Actually, there's not much in the literature to say that this would have happened. So the only comparable thing is motor cortex stimulation, which is not deep brain stimulation, but that's the closest comparable thing for chronic neuropathic pain. And there's an early post-operative seizure rate of 12%. But the seizures from motor cortex stimulation are not subtle. They're not the 2-3 second behavioral arrest that you saw and that none of you spot, that no neurologist would spot unless you have an EEG on them. They're tonic contraction, so it's impossible to miss. So you don't stimulate above the seizure threshold. With ACC seizures, DBS, the seizure semiology varies widely. So you have the behavioral pause, you have the speech arrest, you have the tonic contraction of the limb, you have the autonomic features. ACC DBS is so varied, and the events are so brief and so transient, they're easily missed. And that's one of the difficult things about this. Spontaneous stimulation-induced seizures, 12 months is unexpected and, in fact, unprecedented in DBS literature. So there's no way that even if this came to me 4 years ago for an opinion, I would not be able to predict this. There's just no background in the literature. And as a result, there was no effective surveillance. And if there's no effective surveillance, things need to build up a head of steam before it's spotted and picked up. And that's really what happened here. So why does it affect some people and not others? 4 people affected, other people not affected. Well, the site of stimulation and stimulus parameters are important determinants of whether you can produce after discharges and at what level you produce after discharges in the animal models. And the threshold for after discharges varies widely between individuals, and we know that. We know that from hippocampal stimulation, particularly. And the stimulation intensity required for subjective pain relief varies widely between patients. And I think that's the really important thing, because with when I program for movement disorders, I have objective signs to program to. I don't ask the patient how they're feeling. I look at bradykinesia, or I feel for rigidity, and I know objectively this is the setting they need, not the setting they want, but the setting they need. With pain, you're entirely dependent on subjective pain relief. And so you have to listen to the patient and tune to that patient's request, and that varies widely. Lead placement may also have a role, but particularly deeper contacts may contribute more to this, because if they're embedded in the corpus callosum projects strongly to the ACC in that area, and that might feed this kindling network. And then that leads us to the question, if you carry on with this procedure, are seizures inevitable? Are 15 to 30% of patients going to get seizures or de novo epilepsy? I think the answer to that has to be that it does not develop overnight. It occurs months after months and months of unchecked stimulation. So if you have the proper safeguards, if you have a system where you don't stimulate above the after discharge threshold, and we can determine this individually for patients in the externalization period, and if you follow them up with regular EEG and not just rely on them to tell you that they're having events, the odd event, well, de novo epilepsy shouldn't develop because you can detect it. And if you can detect it, you don't stimulate above a certain threshold, they don't get this side effect. So knowledge, now that we know, we can put steps in place, I think, to stop this happening. So even though you can stop this happening, is it ethical to continue? So the important thing to consider is these are patients for whom this is the option of last resort. I've seen procedures for some of these patients that I've never read about before, that I didn't know were possible. Intrathecal morphine, I didn't know that was a treatment option as a neurologist, but patient 3 had intrathecal morphine. Many of them have had the standard DBS targets for pain already, the thalamic targets for pain, they've had already failed. So these are patients who are literally at the end of their tether and at the end of the line for therapeutic options. And that needs to be kept in mind. And as I said before, de novo epilepsy does not develop overnight, and we can probably prevent it. So I took this to the ethicists at the Oxford Center for Bioethics, and they said, well, typically physicians particularly, and perhaps not as much surgeons, think in terms of non-maleficence, do no harm. But actually, the risk of seizures is not the only consideration. Intractable chronic pain significantly reduces your quality of life, and doing nothing is not doing harm. And that's a really important consideration. What they felt was that in a situation where you have a procedure that can produce significant side effects, you should rely on patient autonomy. And there are 2 principles there. Rationality, so that the patient should make a rational decision about this treatment. And informed consent. They should vividly hold in their mind the consequences, the risks associated with the procedure when they decide that they want to have this procedure. And I think the best way to illustrate that that's the case is both the patients with stimulation-induced epilepsy, the video that you saw and patient 3 that I described, they're desperate to have the stimulation switch back on. It's not just them they're desperate, the families are desperate, the family's right, the physician's right, the pain neurologist, the neurologist's right, the pain physician's right. I've been bombarded by emails as the person who's causing Anis the grief because I've switched off their stimulator and stopped the program. I've gone backwards. And I wanted to put that up because this is the patient in the video that I switched off for 3 months. Her husband stopped talking to me. He doesn't write, he doesn't talk. He holds me responsible for switching it off. Because she's now entirely, she's virtually unresponsive. She's on doses of opiates that I have not seen prescribed before. She needs to sedate herself to the point of oblivion to actually cope with the pain. They can't cope with pain, so they have to sedate themselves, really. And that letter, it doesn't project very well, but it tells you in the first couple of paragraphs what's happened, how terrible the pain is, and how terrible her life is. She praises Tipu. Regrettably, and in the second last paragraph, I'll read this out. It says, regrettably and at present, on medical advice, that's me, my DBS device is turned off, and it's a source of great distress to me that the original pain has returned, and I am now on increasing doses of opiates. This is also an issue of great distress to me. There's only one mention of seizures in this whole letter, and it's right at the end, and it just says, can you sort it out? Can you manage the seizures and just restart my stimulation? So, clearly, what's next for ACC stimulation is that we have to recognize that this is a procedure with some risk. The risk can probably be mitigated with the right steps now that we know. And we need to put in the right framework for this program to continue for the right patient, for very selected patients. So we took it to the neurology M&M. That's how I got involved anyway, because I'm the neurology M&M lead. And then the neurosurgery M&M recently. And then finally for a departmental governance review. And I think the final conclusion will be that the program should continue. But this time round, it should be under the rec with research ethics, because that brings in some monitoring and a fixed regulation scheme, and I think that's a good way to proceed. And that's how it's going to progress. I wanted to end on this. For the young pioneers in the crowd, surgeons tend to be more pioneering than physicians. If you take nothing else away from this episode, you have a recipe for being a pioneer, which is you need a cup full of compassion. You know, your pioneering procedure, if it addresses your patient's needs, you won't get in too much trouble. A pint of honesty, and if you're doing something pioneering, be honest with your patient. Say, look, this is brand new. It's never been tried before. There are the known risks and there are some unknown risks. And your patients will accept that because they know you're doing it for their benefit and you're taking some risks on their behalf. And none of the patients who've developed seizures have complained. The only thing they've complained about is that the neurologist switched the DBS off. You need a pinch of caution if odd things might happen. There are unknown unknowns when you do a truly pioneering procedure. And when odd things happen, react. Involve your colleagues, sort it out. You need a handful of humility, and that's really important. I've been in the business 2 years. I think Tipu's been in the business 25 years. But when I asked Tipu to stop the procedure stopped. No questions asked, and that's really important. When we sort it out, we can restart it again. And then you need patience and persistence. I think if you've got a procedure that you know works, there will be a few bumps in the road, iron out the bumps, and carry on. Thank you.